Hello, today we are seeing the second part of our studies on scaphocephaly, and this is about the surgery and the results and how they are evaluated. And on the right, you have a nice picture of a pope of the past who had a typical clinocephaly. So, as we said, we have different techniques according to the age of the patient and according to the pathology and the presentation. We have to take care of the morbidity and mortality, so we have to think before we operate about the balance of risk and benefits. So the indications will be different according to age, and the criteria for success will be sometimes difficult to assess, as you will see. So the aims of surgery are morphological correction, of course. We have to give the child the head he should have had. This is very often the demand from the parents. And this is the aim of cerebral decompression, which is prophylactic in the infant. He has not yet intracranial hypertension, but in older children, they present with Chiari or papilledema, and they may evaluate so if we don't operate them earlier. We lack scientific evidence about that, but because we used to perform ICP monitoring a long time ago when I was a resident, but it has been abandoned because it was not giving much information and it was invasive. Cerebral decompression is the main goal of surgery when we operate late in case of Chiari or loss of vision. So the objectives of cerebral decompression are to expand the calvaria, to relieve the pressure when there is some hyperpressure, and also to allow the postoperative growth with sustained progression of the head circumference along the new line as illustrated here. So the follow-up criteria will be the fundoscopy, the imaging to see if the arachnoid spaces are restored, if the tonsils do not go down, if there is some fingerprinting, and also the neuropsychological testing, which have to be done later in life during school years. So, what are the objective criteria of morphological correction? Now we have, of course, the craniometry. We measure the head circumference. We calculate the cephalic index. We have to assess the ossification. Are they persistent lacunae? We are going to see at the end of this talk what this problem, how this problem can be coped with. And is there an irregular surface of the of reossification? And we have the Whitaker grading, which is graded 1 to 4 according to the indications or not to reoperate. However, this is a very imperfect index because it mixes morphological problem, complications, and progression of disease. So we certainly need a more objective way to evaluate the morphological correction. We have to evaluate how do we achieve the aim of morphological correction, which is that the child can be able to disappear in a crowd. And the problem that he will face in society is taunting at school, which begins at primary school. This one was nicknamed rugby ball, and this one was nicknamed banana skull. So this can be very distressing for the child, and it impairs our social life. So do we evaluate the parents' appreciation? Very often the parents are very content with the surgery, and when they say it is perfect, it very often means never touch my child again. So it's not objective. The surgeon's appreciation is generally more objective and more demanding. However, we have biases when we evaluate the result of our surgery. We evaluate relative to the to what we expect from the technique we use, and also from whenever there is a solution to a problem like bone irregularities, for example, we don't have good solutions, so we don't consider it is a problem. And then the child's appreciation we have to seek if the child can appreciate himself. What is his hairdo, his hairstyle? Does he develop school phobia? And it can be very telling. So what are the surgical techniques we have to propose? Here we have this wonderful engraving from a Japanese artist, and if we zoom up, we see the area where we are going to focus. So surgery in the very young, around 5 months. The rationale is that we do just suturectomy. There is no facial correction needed because the brain will finish the job by being the engine of correction. In fact, we just liberate the growth by removing its tether. The advantage is that the surgery is limited. It is less hemorrhagic than more complicated surgeries. The drawback, of course, is that the child is very small and we create some problems with our anesthetist. There are some surgical variants, as we shall see. The peninsula outline, the remodeling of the output, and the endoscopy, which can do the same, achieve the same aim with shorter incisions. But I must admit, I personally am not very convinced of the benefit of endoscopy. So how do we install the children? We use a ventral position using a vacuum mattress or a gelatin pads. We put the head in the horseshoe headrest in order to expose the whole of the vertex region from the greater to the lesser fontanelles. And this leaves the forehead available for the anesthetist. They can use the nurse monitoring, which makes them very happy and very confident to know the time when the transfusion may be needed. So the original technique developed by many authors is a bare skin craniectomy. So it is done at 4 or 5 months in the ventral position, and we liberate the parietal bone flaps from the occipital squama down. We go down to the asterion to remove bone and liberate the parietal bone, and from the frontal bone we descend not as low, hoping that the parietal bone will tow the frontal bone and correct the frontal bossing. And there is an optional thing that can be done is a daisy flower remodeling of the occipital squama. So what we need in practice are very few instruments. We use the Wegener regime. We have some a gauge, a craniotomy, and bipolar coagulation. We use a binaural incision, which do not go down to the ear, but it has to be enough extended. We do a subgaleal dissection, which gives very little bleeding and allows good reossification with regular bone surface. And this is the outline of the craniectomy. We do trepanation using the regime. There's no need for an engine, and on this very thin calvaria at that age. And then we elevate the dura using the Jiggly saw guide. And then we do the craniotomy following the outline, and this is the piece we have removed, going down to the asterion posteriorly and a little bit less frontally. So we do a periparietal craniectomy. And we have, of course, to be very wary of doing hemostasis of the emissary veins in the parietal region. The peninsula technique was developed because of the risk of poor reossification in the posterior region. So we have basically the same technique with hemostasis from the emissary veins, and we think the correction is equivalent to the bare skin technique. And there is also the option of doing the daisy flower remodeling of the occipital squama. And this is what we do in practice. We use the same instrumentation. We do the same incision, subgaleal dissection, incision of the periosteum, but we just spare the posterior crest of the midline in order to allow better reossification. And this is the outline of the craniectomy and the piece of bone which is removed one piece sometimes. And we also have to be very careful to do the hemostasis of the emissary vein, and we may be able in clinocephaly to remodel the crest using the Tessier's bone bender. So this is an example of a child operated doing with a peninsula technique and daisy flower remodeling of the occiput. So the operating time was 42 minutes, which is a little more because of the remodeling of the occiput, but generally it's less, it's about half an hour. No transfusion, and the morphological were good, with the head circumference going down from 2 standard deviations to 0 standard deviation, and the cephalic index from 69 to 80. In older children, starting from 9 months, and toddlers, and even older children, the objective is to decompress the skull. The rationale is that the bone gets more and more rigid with time, and the calvarial growth has much slowed, so that we correct the scaphocephaly and give the child his definitive head shape. So we correct the salient features, which are the frontal bullet, the temporal and parietal narrowing. Because the bone is more rigid, we do a cranioplasty, not a linear craniectomy. We reshape the calvaria to its definitive normal morphology, and we correct only the features which can be corrected from the front, and the occipital bullet cannot be addressed in the same session. There are some surgical variants. You can do just biparietal flaps, but it does not correct well the frontal bullet, in my opinion. And there can be also there can be the frontoparietal remodeling, and I think it provides a better correction of the morphology. So the theory of the frontoparietal remodeling is to address the frontal bullet. So we do a frontobasal flap, which is repositioned on the bondo in lordosis to correct the frontal bullet, in valgus to correct the temporal narrowing. We do a parietal fan-shaped flap, which is repositioned laterally, also to correct the temporal narrowing and the parietal narrowing. It is also replaced anteriorly in order to shorten the anterior parietal diameter, as I will show, but overall to buttress the frontal flaps, as I shall show. And in order to avoid the clown's hat in the bregmatic region, we fixate the midline on the frontal bone flaps. And the occipital bullet, as I said, should be forgotten by letting the hair grow. So the installation is in the dorsal position. We use a vacuum mattress or gelatin pads. The head is in a horseshoe headrest. The head is elevated to lower the venous pressure. In the neutral position, we need to expose the orbital rim. And the forehead will not be available to the anesthetist to use NIRS monitoring. So this is the craniotomy. We need to fill the temporal hollow, to correct the frontal bullet, to correct the parietal pinching, and forget the occipital bullet. So this is what we do. The frontal bone flap is split in two and displaced in valgus and lordosis to correct the frontal bulging and fill the temporal hollow. The parietal bone flap will be advanced in order to buttress the frontal bone flaps, and the frontal bone flaps are fixated to the vertex, to the midline vertex. And the fixation of the frontal bone flaps is a bit tricky, because we fixate the frontal flap end to end medially on the orbital bondo, and in overlap laterally which will correct the frontal shape. So this is how we do. We do subparietal dissection. We do some 3 burr holes, 2 on the keyhole and 1 posteriorly in the paramedian region in order to cleave the sagittal sinus. This is the outline of the craniotomies. Then we do a frontobasal flap, which will be then split in 2, and 2 parietal fan-shaped flaps, and leaving in the midline the medial crest. Then we replace the frontal flaps end-to-end medially and in overlap laterally, leaving an interfrontal gap which will reossify very fast in the following months. Then we replace the parietal bone flaps, translated laterally and frontally to buttress the frontal flaps. And we may need the Tessier's bone benders if we need to remodel the midline crest. So this is an example with this technique. We obtain a good facial correction, but you see the occipital bullet is persistent. The duration of surgery is longer than in craniotomy, 109 minutes. He didn't require transfusion, and his head circumference, in fact, was increased, and the cephalic index was very little increased. But the morphology was much appreciated. So how do we appreciate the morphological outcome? This is a study I performed during my Lille experience from a prospective registry from 2014 to 19. So I collected 75 cases which had a first surgery for scaphocephaly. 42 had a craniectomy and 33 had a cranioplasty. Every time it was possible, we did a craniectomy, but many children arrived too late to have this surgery scheduled in time. And we did the evaluation by head circumference, cephalic index, and the morphology scale. The follow-up was about 20 months. We didn't have mortality and no important morbidity. And so the ages were, of course, different because the technique was different, but the children was not statistically different regarding the cephalic index and the head circumference. So we used a semi-quantitative rating inspired by the Rotterdam scores, rated 0 to 2 regarding 5 items, making a total score of 0 to 10. And it work? So never mind. So this is an example of scoring in a child who was followed for 2 years, because initially the parents did not want surgery. And this is the evolution of a cephalic index, which was in fact decreasing, showing an increase of the scaphocephalic appearance. The head circumference, in fact, was also decreasing, and the morphology was not varying much except for the frontal bulging. But finally, the parents opted for surgery because of the concern regarding her entry at school, and they were afraid of teasing and unease from the child. So these are the results of the study. The modification of the cephalic index was better with a craniectomy than with cranioplasty, while the difference in head circumference was not statistically different. So we see that there is a clear improvement of the cephalic index after surgery initially, but there is a rebound effect in the later period. And the head circumference, we have also a decrease of the head circumference, which is abnormally high, as said in the first part of this lecture. And there was also a rebound effect later on. So with craniectomy, we have a significantly better correction of the cephalic index, while there is no difference between the techniques regarding head circumference, and there is a rebound effect with both techniques, but maybe less pronounced with craniectomy. This is the results regarding the morphological index in the different items, that is the frontal, occipital, vertex, parietal, and temporal from 0 to 2. There is no significant difference between the techniques regarding the different items. However, the total, the sum of the morphological score was significantly better for the craniectomy than for the cranioplasty. So with craniectomy, we have a better correction, which appears to be more sustained in time. So clearly, whenever possible, it's better, I think, to do a craniectomy at 4 months than a cranioplasty later in life. What complications do we have in surgery for scaphocephaly? Of course, we have the problem of the scar, which are increased by the drain. So we have ceased to use drainage in these children because we have some complaints about the scar it left. We have different incisions, which are have the general idea of all these incisions is to avoid the scar being visible by doing the incision as much as possible 90 degrees from the direction of the hair. The endoscopic surgery is supposed to leave a less visible scar. However, it's much more anterior and may be visible later in life. And there may be some complications like sepsis, redness of the scar, which will subside with time, and keloid sometimes. And in fact, the question we ask to the child is, how do you comb your hair? How do you clip your hair? Do you suffer from teasing or taunting at school when you regarding your scar or when you go to the swimming pool? And clearly, some children do not give a damn to that, as you can see there, and some of them even can glorify their scar, as you see here. So then there may be lacunae, that is defective reossification after 4 years generally. We can hope it can reossify during the first 4 years or even 5 or 6 years. The question of the parents is, do the child need a helmet? They don't, because if they fall down, the impact will be on the frontal bone or the occiput or the lateral sides of the skull, but not on the apex. And we repair that using the split calvaria technique. We put the child in the prone position. This is the receiving side, and this is how we fill it using split calvaria, taking a donor side, splitting the bone in two, and replacing it in the donor and the receiving side. So the surgery is generally performed about 5 or 6 years because at that time the calvaria is much thicker and can be split very easily. We can also have the problem of growing fracture, which is caused by breakdown of the dura because of tearing during surgery or dural necrosis after surgery, and it can lead to brain herniation. This is an example of a child who had an endoscopic surgerectomy in another center at the age of 3 months. He had a parasagittal dural tear, which was incompletely repaired. He had a second endoscopy and a third surgery. When he came to our center, we first did a lumbar drainage and a split calvarial autograft because there may be a CSF circulation problem in these children, and this one required external lumbar drainage before bone repair, doing autologous split calvaria. And at that age, the piezotome can be very helpful to split the calvaria of a 1-year-old child. And these are the results with the donor site and the split calvaria. So clearly, this is a major undertaking and certainly more important than the initial surgery. So it's a Whittaker 4 or even 5 if we could extend this scale. So in conclusion, the surgical technique for scaphocephaly must be tailored to the child's development. Early craniectomy is the best option whenever possible, but the later cranioplasty is a valuable second choice. and morphology should be quantified using common metrics, and it would be nice that we could develop consensual scale for morphological evaluation, like the metric system which was adopted by the whole world with a small exception. I thank you for your attention.